Hi, everyone. My name is Teresa Casanovas. I am a pathologist and now ELPA Scientific Committee Coordinator. On Rare Liver Diseases Week 2023, we would like to update you about some rare liver diseases. Today, we will talk about Wilson disease. It is my pleasure and honor to have Dr. Marina Berenguer presenting on the updating Wilson disease approach, early diagnosis, and management in 2023. Dr. Marina Berenguer is committed with the liver patients. I would like to introduce her, and I would like to highlight in her introduction only some critical aspects of her professional life. Dr. Marina Berenguer is a pathologist involved in clinical care and research. She has authored hundreds of scientific publications, and now she is working in Valencia, Spain. Dr. Marina Berenguer is a consultant hepatologist and professor of medicine at La Feu University Hospital, Valencia. She is well recognized for her important contributions to the field of post-transplantation hepatitis C liver diseases. Marina Berenguer is the past president of the International Liver Transplantation Society. She's an expert on Wilson disease, and recently she has coordinated one multicentric study about the clinical diagnosis and treatment of Wilson's disease. And in this work, authors talk about Wilson's disease and the challenges that have not yet been overcome. The title of the published article is Significant Heterogeneity in the Diagnosis and Long-Term Management of Wilson Disease, Results from a Large Multicenter Spanish Study. Please, Dr. Berenguer, the floor is yours, and thank you very much.
Well, thank you very much, Teresa. It's really my pleasure to be here to talk about Wilson disease. I've been taking care of Wilson disease patients for the last 25 years. And I think the first conclusion that we get from seeing these patients in the long term is that they do have, and they should have, a good prognosis. And this, in order to ensure this good prognosis, we need to really make sure that three pillars are really taken care of. First, an early diagnosis. It is essential to have a good prognosis. Second, these patients require long-term therapy. We have efficacious treatments, but in order to maintain treatment in the long term, we need to ensure an adequate monitoring, and we need to ensure also the lack of toxicities in the long term. So for an early diagnosis, the main point, I believe, is that we need to think about the disease. And there is, I think, one point that we should perhaps improve in the long term, and that is education to the younger physicians, primary care physicians, gastroenterologists, neurologists. This is a very diverse disease with many manifestations. They are not only liver and neurological. There's a large variety of organs that can be affected. But overall, I think it is important to remember that children and adolescents and adults with elevated transaminases of a known cause, we should be thinking about Wilson disease, cirrhosis of an unknown cause at any age, young people with tremor, movement disorders, dysphagia, dysarthria of a known cause, adolescents, and this is a very important point, with behavioral disorders or school problems with increased transaminases, and fulminant hepatitis without apparent cause. We do have, the second point is, now that we think about the disease, we need to make the diagnosis. And unfortunately, there is one problem, and that is that there is really an absence of specific and highly sensitive diagnostic tools. Quite often, these tools, they are either very sensitive but then lack specificity, or they're very specific then lack sensitivity. And hence, diagnosis currently is based on the Leipzig score, with many different laboratory tests that we need to perform with the limitations of these tests. I think the main improvement in the last years has been really in terms of genetic evaluation. However, we need to understand that there are over 900 mutations in Wilson's disease, very heterogeneous, with a different distribution geographically. And most importantly, I think we need to understand that there is not always a good correlation between the mutation and the phenotypic presentation. In addition, in some of the mutations, we may not know the impact that they have on the enzyme. So let's just think about the transmission of a recessive trait. We know that this trait, we will be having both the allele, the mutation in one of the alleles of the parents, of each of the parents. And in terms of Wilson disease, three things can happen. In general, in a person without mutations, we will have 2 officials per task, and then they will work in combination to make the best prognosis. In patients in individuals who only receive one allele, the carrier of only one allele, there will be one room, but this will be sufficient to perform a good task. Finally, when the 2 alleles are affected, then that's when we have problems with maintaining adequate elimination of the copper from the liver. However, even when 2 mutations are present, there may be some additional gene modifiers, epigenetic issues that may have an impact on how this copper is eliminated from the body. So in general, we need to understand that genetic testing alone is not enough for clinical and therapeutic decision-making in asymptomatic patients with Wilson disease, that mutation testing is insufficient to predict pathogenicity, and that overall, when we have symptomatic patients with 2 mutations, we need to perform a complete diagnostic workup, including MR of the head in patients with liver manifestations. Finally, when we decide on treatment in patients with variants of unknown significance, this should be based on clear and specific phenotypic evaluation. Asymptomatic patients may be left without treatment, but then they must be regularly monitored, and best clinical and therapeutic management of these patients will still need to be defined in future clinical studies. The second pillar is really lifelong treatment. Again, this is essential for good prognosis. We have different therapies that avoid entry of copper in the body, therapies that eliminate the excessive copper, and finally, therapies that fix the copper in the cells in an atoxic way. The problem, we need to start with one of these drugs. We need to maintain with a drug that has the least toxicity, but the highest efficacy in the long term, but also the higher compliance. And this varies substantially from one patient to the other. So there is clear no one-size-fits-all remedy. We need to understand that treatment failure is not related just to one single reason. It is multifactorial. It may be due to toxicity, to lack of long-term compliance. It may be due to the fact that this drug is not adequate. It's a primary failure of the drug to eliminate the excess of copper. And finally, and I think this is very important, we need better assays to determine the free toxic copper to aid in treatment monitoring. And there may be new assays that are coming, exchangeable copper, for instance, that appears to be a better assay to really assess treatment monitoring and treatment compliance in the long term. Finally, we need better also drugs. We do have good drugs, but we need better ones and potentially less toxic ones, so that we have a variety of tools that we can use to treat our patients. And fortunately, there's been advances in the last year, and there will be advances in the next few years. There was just one large, very important trial that was published assessing trientine tetrahydrochloride for patients who are stable under penicillamine. So we have a new drug that can be used for patients who have problems with penicillamine. We do have another drug, which is a tetratiomolybdate biscoline, which is also undergoing now the last analysis to be published in just probably in a few months. Again, with different methods of activity. Some may be more chelators, some may have some activity to prevent the absorption of copper in the duodenum, and then others may fix the copper in an atoxic way in the cell. Particularly, I think a very, very important aspect is to create multidisciplinary units in tertiary referral hospitals to improve the management of Wilson disease and the diagnosis of Wilson disease patients. And I think this, again, is something that we need to work on for the future. Finally, gene therapy might be a reality. It still needs to finish the studies that have already studied in human. We now have data from the animal model that shows that the liver can be transduced in 20% of the cells. And this is associated with an adequate job of the enzyme, such that fecal copper excretion will be normalized in these genetic test treated mice. Urinary copper expression will be also normalized, as well as hepatic copper content, histology, survival, ceruloplasmin levels, because the enzyme is completely corrected. And finally, hematology and serum liver biochemistry is also normalized. These are studies that have been performed in mice, and now we need to confirm the data in humans, and the studies are underway. So I will finish just commenting that this has been really a century of progress on Wilson disease. There have been many advances in diagnosis, particularly in terms of genetics and in treatment, but we still need to go on, and we need to make more progress in the future. We need to understand how to best use DNA sequencing to improve Wilson disease diagnosis, whether we can really discover the role of modifier genes in terms of diagnosis, whether we can improve specific copper measurements, whether what is the role of autoimmune antibodies in Wilson disease. In terms of treatment, we need really to understand whether we should individualize this treatment based on patient age. What is the best approach for monitoring? What is the best tool that we should use for monitoring? And finally, in terms of disease modeling, how relevant are organoid models? From a patient perspective, I think it is very important what is the best advice from healthcare professionals for patients, but also what is the best advice from patients to healthcare professionals. And with this, I really would like to thank all the associations, patients associations. We do have in Spain a very strong Wilson disease patient association, and they are really critical to implement and increase our understanding of this disease, particularly in terms of quality of life and what needs to be done for these patients, for them to have a good survival, but also a good quality of life. Thank you very much.